enjoy having the Rothman folks participate. I know you have your fellows involved, so thank you very much for doing this tonight.
Absolutely. It's my pleasure. So we're just going to start out with, if I can actually back this up a little bit. Start out kind of with a discussion, right? So today we're going to talk about degenerative spondyloltitheis, and is a fusion really necessary? And if so, what are the best techniques to do it? So myself and Chris Kepler are here from the Rothman Institute, and then we've got 3 of our fellows who are with us today. Caleb Young, Mike Nolte, and Hesh Saleh are with us, as well as Taylor Pasek, who's one of our residents who's doing fellowship at the Cleveland Clinic next year. So we got a bunch of great cases that we're going to talk about. Just kind of some basic background for it, right? We all have heard that, if you have a degenerative spondylolisthesis, you need a fusion. And, the interesting thing is when you kind of dig into why that is, it goes back to this article from 1991, right? There were Herkowitz, 25 patients in a fusion versus a no fusion group. There were no patient-reported outcomes, except they reported back and leg pain, and their follow-up was at 2.4 to 4 years, and they had a statistically significant improvement. This is a paper that realistically at a lot of journals wouldn't even get published today. And yet this is what we have basically told residents over and over and over again, that they need to fuse. I mean, when I was a resident, it's hard to believe it was like 10 years ago, it was always, if they have a degenerative spondylolisthesis, they need to have a fusion. But is this really true? Right? I mean, back in 2016, we had 2 different studies, prospective randomized trials. This one was out of Europe, where they looked at, do patients who need a fusion? And the interesting thing is when you kind of look at their results, right, they had 113 patients who had a fusion, 119 patients who had a decompression alone. The length of hospital stay was a heck of a lot longer in the fusion group. But other than that, realistically, that was about it. We have kind of things like number of visits to healthcare professionals, but operating time and bleeding was a lot higher in the fusion rate. But realistically, the health-related quality of life outcomes, there was no statistical significant difference. Kind of the same year, Zogawala looked at a group really out of America, prospective randomized trial comparing 35 patients in the decompression alone versus 31 patients in a fusion group. And what you saw here was they actually, again, found an increased rate in the estimated blood loss, as well as the hospital stay and the duration of the surgery. But they did find an improvement really in SF36, as well as ODI at 6 months, really through 4 years. So I think there is a little bit still kind of a question in the literature with what is better. Why do we have one study saying one thing and another saying another thing? Fast forward to 2021, there was another prospective randomized trial, this time out of Norway. Again, these were patients who had a degenerative spondylolisthesis. And interestingly, in this study, they even included patients who had motion on flexion and extension film. So oftentimes we say, oh, well, if they have motion on flex, actually got to get a fusion. They still didn't find a difference. No difference in patients who had a fusion or no fusion in terms of reoperation rate, in terms of health-related quality of life outcomes. And then it kind of in 2021, however, we had kind of a contradictory study where there were 608 patients who had a degenerative spondylolisthesis. And here they actually did find a statistically significant improvement in the patients who had a fusion versus a non-fusion. When you look at all of this, what does it mean? Well, it means whenever you do a systematic review, this was a recent systematic review, they're not going to be able to find a difference. So the question is, who really needs a fusion? There was a study looking at a survey of LSRS members and the Society for Minimally Invasive Spine Surgery. Only 20% of surgeons in 2022 said they would fuse all cases. About 40% said they would fuse more than 75% of the cases. And this is really a stark change from when I actually did this study back in 2015, where here 47% of surgeons said they would fuse all patients. So I think what we look at it is we don't even know necessarily whether or not all of these patients need a fusion, who needs a fusion, who's going to do better with a fusion, much less when we take that and say, all right, well, now let's throw in, how are you going to fuse it? Are you going to do a PLDF like Dr. Kepler does the vast majority of the time? Are you going to do a lateral like I do the majority of the time? Alex does a TLIF and Jeff Ryan does a TLIF all the time. And sometimes people do a decompression only. So who knows what the right answer is? So I think that that's one of the fun things about this kind of venue is we're going to take 4 cases. I think you could make an argument to treat all of them in different ways. I don't know if these are all my cases, but I will tell you, I looked back over the last month, I have treated all of these cases in a decompression only, a posterior lumbar decompression infusion, a lateral, and a TLIF. So I think there's lots of discussions for why we would treat one way versus the other way. So at this point, I'm going to introduce the fellows and have them start. Thanks, guys. Stop sharing my screen. All right, and why don't we have who's going to ever start with the probably posterior lumbar decompression infusion go first, as that's probably the most straightforward one.
All right, that'll be me. I'll get started. My name's Taylor Pazook. I'm one of the chiefs at Rothman and Jefferson. And like Dr. Schroeder said, I'll be heading to Cleveland next year. So the first case is going to be, can't see much, 76-year-old active guy, progressively worsening back, bilateral lower extremity symptoms in addition to some neurogenic claudication. They kind of progressed despite kind of extensive non-operative therapy. It didn't really have a contributory history outside from his past medical history, surgical history, things of that nature. And his exam was, again, relatively unremarkable with the exception of maybe some weakness in his EHL. Here is presenting radiographs. As you can see, he does have a degenerative frontal plane deformity in addition to a spondyloltitheis at 4-5. On flexion extension films, you can see he does translate anteriorly at 4-5 with flexion, consistent with an instability type pattern. Here's his associated MRI, delineating moderate to severe lateral recess and central canal stenosis at 3-4-4-5. In addition to imaging of his foramen both on the right and left, showing moderate to severe foraminal stenosis on the right and relatively open on the left. So again, what do we do with it? We kind of talked about those beforehand. You can do really anything here, even with the instability on flexion extension. You can do an isolated decompression. You can do a posterior lateral fusion or an indirect decompression and a 360 fusion if that's what you wanted to go down. Things you want to consider: instability on flexion extension films, albeit the study that Dr. Schroeder mentioned prior didn't really show that mattered. Dynamic component of the neural compression. So even if you did feel like you were able to decompress the foramen laterally with a simple decompression, if you weren't able to account for the dynamic component of the neurologic compression, the patient may not have resolution of their symptoms. If they did have a component of axial back pain, whether or not fusion would help with that or has the ability to do so. Again, sagittal alignment of the facets. So if the patient has a propensity to slip further with iatrogenic decompression and instability from taking down some of the lamina, and then a possible bony component to the subarticular lateral recess stenosis. So if you were going to do it all indirect, would you adequately decompress the lateral recess and the traversing roots? So this is what we ultimately ended up doing: a 3-5 decompression, 4-5 fusion, all from the back. The patient did extremely well and has done extremely well 2 years out now, with just going in from the back. Thanks.
All right, thanks, Taylor. I mean, right, so when I looked at that case, I mean, to me, I do a lot of laterals, things along those lines, but if you need to have a decompression kind of at the adjacent level, to me, that's a good indication to do kind of traditional posterior lumbar decompression and fusion, because I feel like oftentimes, I mean, yes, you can do it other ways, but it's, you're already there. It's so much quicker to get the nerves decompressed, and then just to stabilize the one level. So I think that's really a pretty straightforward, good case for that. I mean, I think one of the questions that is always brought up, at least for us, is, all right, so you did a PLDF, why didn't you include an interbody? I mean, do you think that an interbody would have added anything to that one, Taylor?
I don't necessarily think so. If you look at the disc space, kind of on the preoperative films, it looked like he was relatively preserved. I didn't think you really had any significant craniocaudal compression. And if you were able to adequately get out into the frame, and I think you'd be okay. I don't think there's any literature to show that putting an interbody in increases your fusion rates as long as you get a good, intertransverse bone graft. And I think, isolated fusion in the back is more than adequate in this patient. 76 years old. End plates probably aren't as good as you might want, especially if you're just doing it from the back with a smaller, cage like a TLIF or something of that nature. But I think it's an option. I just think getting it all from the back is fine as well.
Dr. Chapman, you look like you got your hand raised. What do you want to say?
Sorry, yeah. So I thought this is a great case. I congratulate you on raising this issue of interbody cages, and we've kind of reflexively gone to that more and more. And de facto, the literature, like from Sweden with lumbar fusions for 1 to 2 levels, did not ever show an actual difference of blood loss or clinical outcomes. So I still do it. I think I can get a better lordosis. I justified with that, but I think that's very cool. In the bigger picture, Greg, you're one of the most organized people I know. Are we ready to have like a checklist? This is a beautiful kind of a summary of points that your fellow brought up, or the resident brought up. And I think this is just one of those things that we can probably more formalize in the future, like alignment, facet joint alignment, fluid in the joints, amount of kyphosis, lordosis, disc degeneration, adjacent segments, bone density, yada, yada, yada. Do we have a checklist? Do you have a checklist outside of that brain of yours?
I mean, I do not have a formal checklist that I use. I do think that it would be hard from an evidence standpoint to put together a checklist because of just what I showed when we started, right? It's challenging to really determine who needs a fusion, and the literature is really all over the map on this. So in my mind, when I look at that, right, I look at it, if you are older and a sicker patient, I'm immediately thinking maybe you're going to get away with the decompression. I know the study I quoted out of Denmark suggested that if you have instability, you don't necessarily still need a fusion, but that's one that is like, in my mind, it's really challenging for me to wrap my mind around how, if you have, multiple millimeters of movement on flexion and extension films, I'm not going to fuse that. So I think that in my mind, I do look at kind of the fluid and the facets, things like that. But the bigger thing to me are patient factors, right? If you have a BMI over 40 and you have severe stenosis, in my hands, you're getting a decompression every time. Like even if you have motion. And I'm going to tell you, it's not safe to put in screws because I just don't want to deal with your infection. If you are, 85, even if you have a little bit of motion, I'm probably just doing a decompression because I don't really care what your 10-year outcome is at that point. So a lot of it is also kind of looking at the patient. There's the morphological factors, but I think there's also a lot of surgical factors and patient-specific factors. I will comment. I will say, you're talking about interbodies. With TLIFs, I stopped doing a lot of TLIFs probably 2 or 3 years ago because I got tired of publishing paper after paper after paper that showed that it didn't matter. And Chris Kepler constantly doing PLDFs and telling me, listen, we just published 4 papers in the last 6 months that showed that they don't matter. And yet I was still doing them. So speaking of TLIFs, why don't we go next to our case that we did do a TLIF on?
All right, so I'll present this case. Okay. All right. So this is a 64-year-old female with a degenerative spondyloltitheis. So she presented with 1 year of bilateral leg pain and claudication worsened with activity. She had already trialed physical therapy, physiatry, and NSAIDs with minimal relief of her symptoms. Past medical history, she was osteoporotic, but really otherwise healthy. She was on bisphosphonate as well for that. She's a retired teacher and a non-smoker. On examination, she had 5 out of 5 strength and intact sensation throughout her lower extremities. She had some decreased range of motion of the lumbar spine, some pain as well. No myelopathy, and then 1+ reflexes in her legs. So these were her preoperative x-rays. And then this was her, or these were her flexion and extension films. Here's a video of her MRI, just the way that it was sequenced by the radiologist. It jumps around a little bit, but let's play. So we kind of already talked about this beforehand, but ultimately TLIF was done for this. She's due to come back in for a 6-month follow-up, but these were her 3-month post-operative x-rays. She had resolution of all of her preoperative symptoms at this time point.
So Kepler, you're on the video. No way you would do a TLIF here, right?
I don't see Dr. Kepler on currently.
Oh, sorry. I thought he was on it. Sorry. So, I mean, Chris is one of ours who I think does the least amount of TLIFs. So, I mean, walk me through, like, so you did a TLIF on this, Caleb, and you used an expandable cage. I mean, why do you use an expandable cage? What was your thought process there?
So the expandable cage in this case, I don't know that there was a particular, I don't think that there was a particular reason to restore disc height. I just think that it was, you know, the osteoporotic bone, I think certainly that gives you a little bit of pause. So it was one of the ones, you know, that we very gently expanded.
Okay.
I don't know that you necessarily needed one. The lordosis here was okay. I just think that this was kind of just surgeon preference ultimately.
Yeah, I mean,
instability there, you know, kind of was the indication doing interbody here, but I think, you know, that can also be like debated, like we were just talking about.
because I mean, I look at this and I think to myself, you have an osteoporotic woman. You're already, you know, I mean, plus or minus whether or not you need the interbody. And then you used an expandable cage. So if your argument is that you want to increase your fusion rate, right? In my mind, you know, and Jens, I'd love to know your thought on this. You know, I think an expandable cage, I can't come up with how it probably increases the fusion rate because you put it in at a 9, you know, you pack it at a 9 and then you jack it open to a 13. And now there's really no bone graft in between there. You know, I mean, I know there are all of these contraptions for how you're supposed to get bone graft in there. But I just can't envision that it really gives you kind of the same amount of bone graft and the same fusion as I would have from a more static cage. So if I was using a TLIF thinking I really need indirect height, then they've got a collapsed vertebral or a collapsed disc, then I mean, I think an expandable cage is great. But in somebody who I'm already nervous about for their end plates and things along those lines, I think that a expandable cage is something that makes me a little bit nervous for that one. Did you guys do this open or did you do it minimally invasively?
This was done open.
Okay. Okay.
So for me, if I may add something, this is aesthetically very pleasing. I don't have the degrees. I can't measure that on my little screen, but restoring the anterior column does at least make this surgeon feel better. And it looks to me like the surgeon who did this actually pushed a nice amount of bone graft outside the cage. I could not agree more with you, Greg, that within the cage, there's no realistic fusion result or nothing meaningful. But this surgeon actually seems to have, on the AP at least, pushed the bone graft to the far side of this cage and really maximized that space very nicely. So the hope is obviously that if we use these expandable cages, we actually improve lordosis and, yes, have a better sagittal alignment. Most of the non-caged posterior fusions kind of sag down. The disc dries out and kind of they lose their alignment for the most part. So this is a theoretical advantage. In an osteoporotic patient, I also agree with you that having a cage in the front offloads the screw interface somewhat.
So that's interesting, Jens. So you think in an osteoporotic patient, a T-lift offloads the screws? Because I think to myself, I'm not going to put a T-lift in an osteoporotic patient because I've had too many of them subside.
If the end plates are properly preserved. So I actually do a bilateral takedown. I put a spreader in so that I don't kind of invade the space. And I do want to acknowledge in one of our papers, we actually measured that very carefully. The expandable cages had the same final alignment as standard banana-shaped cages. And basically the end plates just subside over time. So I want to be completely honest about it. This is why I always preface whatever I said by saying it makes this surgeon speaking here feel better. But in an osteoporotic patient, there's an undeniable subsidence as much as initial x-rays look great.
Right.
Yeah,
I mean, sorry, continue, Dr. Geyer.
No, I just going to say that, I was looking at the x-rays and at the same time was going through my mind, Mike Heisey raised the same question. Do you have any concern about decompressing up to the 3-4 level? It looks like there's no spinous process at all of 4. And now you've taken away your ligament ataxis, at least at the 3-4 level. Are you jeopardizing that level, putting that level at risk now?
So it's interesting. I've been on this before and I've heard you talk about being concerned with that. I mean, at Rothman, whether it's myself or almost anybody else, we routinely will take out, do a 2 to 5 decompression and a 4 or 5 fusion and just not think anything about it. So I know that's not always the answer. And some of that I think may be regional because I don't think that there is a good amount of literature that really kind of says, one versus the other. But in our hands, yeah, we are constantly taking down all of 2, all of 3, just doing a 1-level fusion. So it doesn't bother me in the least. How's that?
Okay.
The expandable T-lift in an osteoporotic lady really bothers me. Oh,
Yeah, that bothers me too.
All right. So, I looked at this and let's do kind of the next case, Dr. Nolte. I probably would have treated the case that you guys just showed the way that I think Nolte is going to treat his next case.
Hey, everybody. I'm Mike Nolte. Thanks for having us tonight. I am one of the fellows. I'm going to be heading back to my home state of Wisconsin for practice after this year. All right. So my patient, 53-year-old woman, she works in sales. She's coming in with a year of primarily leg pain. She's saying right worse than left. Kind of an L5 distribution, maybe some element of L4 kind of crossing over the medial aspect of her ankle. She's got a moderate degree of axial back pain, but again, her chief complaint are her leg symptoms. She does say that her pain in the legs is relieved when lying supine in particular. Otherwise healthy and active. On exam, she's 5'2", 178 pounds with a BMI of 33.4. She does have some weakness in that right 4 and 5 distribution tibia and EHL. Otherwise, fairly unremarkable exam. Clinical impression for her, 4-5 radiculopathy, right side, a little bit worse than left. These are her imaging, initial x-rays, just plain lateral and plain AP. You can see just on the plain lateral does have some instability that is dynamic on those flexion extension views. Has reasonably well maintained lordosis, disc heights overall reasonably well maintained. The rest of the spine looks pretty good. This is her select sagittal cuts of her MRI, redemonstrating that grade 1 spondyloltitheis at L4-5. Certainly some foraminal stenosis at that L4 foramen. both from a cranial caudal, but also kind of dorsal ventral perspective. Right side maybe a little bit worse than the left. Looking at lateral recesses, 3-4 was completely clean, completely patent, but certainly you can see some element of lateral recess stenosis at L4-5, and then L5-S1 actually looks okay, no issues there. And I want to give away what we did for this patient, so I'll hold off on saying more. But in terms of thoughts and planning, you know, Taylor had a great slide kind of on some of the initial things that cross your mind for is fusion necessary, which is kind of the topic of this conversation. So I'm thinking to myself of what's the degree of instability? Is it how much more is it worsening with the flexion extension views? Is there a component of axial back pain? How long have these symptoms been present for? You know, is this somebody who has a pretty significant slip, but they've only had you know, a few months of leg pain and leg pain only? You know, maybe that's somebody who may be more amenable to just a decompression. What's the nature of that stenosis? Is it mostly osseous? Is there some hypertrophied ligamentum? And then I think a big thing too is patient preference. You know, you may have a patient who comes to you and hears the F word fusion and says, "Doc, I'm not ready for that." But if there's something, you know, if there's a lesser option that may be a little bit of a gamble, you know, that's something I'm willing to entertain. So I don't think that we can overlook that as well. So when you do kind of cross the bridge into fusion, you know, you're thinking, okay, how am I going to approach this patient? Does the patient have a clear direct need for direct decompression? That's kind of what we talked about earlier. You know, do they have critical stenosis at another level that needs to be addressed? Would you say that the stenosis is mostly osseous, mostly ligamentous, mostly in a cranial caudal perspective? Does the patient have unilateral, bilateral symptoms? Is their sagittal alignment out of whack? What does their bone quality look like? Is it somebody who can handle and heal a fusion? To Dr. Schroeder's point, you know, is this patient, is their BMI so high that the risks of doing a fusion surgery on them potentially outweigh any benefits? And then certainly anatomical considerations that may render somebody, you know, a good T-lift candidate, but a poor A-lift candidate, for example. So again, this is our patient. Keeping all those things in mind, we thought that this person was a good candidate for an L4-5 lateral interbody fusion. You can see the final x-rays here. This is about, I believe it was 6 months follow-up, patient doing well, reporting relief in their bilateral radicular symptoms, and also some relief in their back pain as well. So again, left-sided L4-5, lateral transpsoas, interbody fusion, and then percutaneous screws posteriorly without a direct decompression. You know, just some things on L-lift or X-lift in particular that I'm sure Dr. Schroeder will touch on. Certainly you want to look at the patient's anatomy, both in terms of their psoas muscle, which is kind of a surrogate for their lumbar plexus anatomy. We're looking to stay away from what's been coined kind of the teardrop anatomy at the top box there, which can be indicative of a more anterior lumbar plexus that may be an issue with the lateral approach. Also looking at great vessel anatomy, you know, is this somebody who vena cava or the veins are more kind of lateral over the disc space and could get in your way either on a right-sided approach, or if you stick the cob too far through the disc space with a left-sided approach. Certainly things you want to keep in mind. And then I think to a lesser extent, iliac crest height, you know, I think there's a lot of focus on that, but certainly we've seen how with kind of the advent of some of these angled tools and just being able to break the bed, how many 4-5 disc spaces that we probably previously thought were inaccessible are actually probably good candidates for LF. So just some things at 4-5, because I think 4-5 is probably still debated, and maybe some people are still spooked by 4-5. So some of the things that have worked well in Dr. Schroeder's practice and our practice here, but initially docking that dilator at the anterior aspect of the disc space, sweeping back, kind of creating a muscle cuff behind you. Really trying to avoid angling anterior posterior. Certainly you don't want to go cranial caudal to the extent that you're going into the, violating the end plate. But you can get into real danger if you start to angle anterior posterior and lose track of where you are. And then in regards to the neuroanatomy, before you place that shim, you run the motor directly to visualize your field, use the probe to test the field. I think that those are all valuable things in helping avoid neurological adverse outcomes. And then certainly we're trying to avoid trans-psoas time of greater than 20 minutes. And oftentimes we're less than 10 minutes, which I think is helpful as well. So certainly welcome any thoughts or questions on this one. I know it's been a kind of a growing area of interest for a lot of people, and thanks for listening.
All right, Mike. Thank you. I think that's a great case. So you bring up an interesting point that I'd love to hear from some of the panel on. So Alex will not do any kind of lateral at L4, L5. He insists that I'm like being super dangerous at doing it. I mean, I do laterals at 4 or 5 all the time. I think you got to be selective about the patients who you do it in. What about the rest of the panel? Does anybody else feel strongly that you shouldn't be doing a lateral at 4 or 5?
You want to pipe in?
This is Chris Kepler. I mean, I think you have to be willing to accept, and this is part of being a spine surgeon. There's a high risk of complications at L4-5 with respect to injured lumbar plexus, but that's where every patient is different. And if you look at the MRI and you think it's okay, and you look at the X-rays and you can get there, maybe you counsel the patient a little bit differently. But I don't think there's a reason to think that this is like a no-go territory for lateral approach interbody fusion. Sort of as a sweeping statement. Although I think this patient was operated on today.
No, I didn't do that today. That's 6 months ago for me.
Oh yeah, that's a different one.
I looked at this case and I thought to myself, is there a way that I can do this that kind of gets the patient in and out of the hospital as fast as possible with less kind of dramatic tissue? I always make fun of Alex when I talk to patients about this and say, it's not a fusion like your Uncle Alex did, where he's got an incision like this long. I tell him we can do it through a couple of small incisions, and people tend to love it and they laugh at me making fun of Alex, even though they don't know that that's what's really happening. I think
we have a question from the we have a question also on the chat.
Oh, sure.
Which says, how do I counsel on the potential need to decompress after lateral surgery for indirect decompression? Greg, what would you say about the likelihood of that need?
I tell every patient that there is a chance that it'll happen, that it is probably under 20%. Honestly, I probably haven't taken anybody back for it in over 2 years. So I think I'm way over counseling it on that. But what I tell people is, listen, if you still have symptoms at 6 months, we can do a small outpatient surgery and just directly decompress the nerves. But then I tell them, but listen, I haven't done that in 2 years. And usually they're not worried about it. Does anybody else tell them anything differently than that?
So we did, there was a study published out of TBI, which Dr. Derman did actually, and the rate was between 3 and 5%. So it was a very low rate of having to reoperate for decompression that wasn't completed with the indirect decompression.
Yeah, I think that 20% is like an old number from when people were starting putting in XLIF cages. And I think they're lateral cages. I think there's a lot of things that you can do, right? You put in a bigger cage, you try to get the spondy reduced. If you do all of that stuff, I just think that realistically, I have less patients with continued radiculopathy after a lateral than I did with a TLIF, probably because I'm not pulling on the nerves. So Eric Olson commented on here, he's one of my former co-fellows, that he's seen more foot drops after T-lifts than at laterals at L4, L5, which I think is a great statement.
Eric, we don't want to hear about your practice.
I've definitely
Just
had more
kidding,
foot drops
just
from
kidding.
T-lifts than from laterals. So, all right. So I mean, I think that that's a great option. All right. I think we got one more case to present. I can't remember who hasn't gone yet.
Hey, I do. Give me 1 second here. All right, so this is a case presentation. 85-year-old female, past medical history of coronary artery disease, presents with 1 year of severe right buttock pain, as well as numbness. Her pain does not radiate elsewhere. She has no symptoms going down her left lower extremity. She rates her pain as 10 out of 10. She has tried non-operative treatment, including physical therapy, as well as epidural injections, which did not provide much relief. She's fairly skinny, BMI 23. Her exam is 4 out of 5 right tibia, 4 out of 5 right EHL, 2 out of 5 right gastrux, 5s along the left lower extremity. On this X-ray, you can see she has a grade 1 spondia L5S1. And then with the, it actually doesn't move that much with flexion extension. So when I measured it, there was probably about a difference of about 2.5 millimeters. So fairly stable. Along the MRI, you can see that she has central canal stenosis as well as bilateral lateral recess stenosis at 5.1. Then if you look at her foramen on the left side, I would say mild stenosis there, and then the right side looked okay. So treatment options, I know we already discussed posterolateral fusions, T-lifts, X-lifts. So this is going to be the most minimalistic approach, which we just did an isolated decompression. So we actually ended up doing a right L5S1 hemilaminectomy. It was through a small open incision, and then we shaved off like the bottom 2/3 of the L5 lamina on the right side, as well as a little bit off the top of S1, made sure that the canal was decompressed as well as the nerves. And then a patient was discharged on post-op day 1. At the 2-week follow-up, her right leg pain has completely gone away. She notes that she has had subjective increase in her strength on the right side, even though her objective motor exam was still the same. And this was a recent case of her, so she's due for her next post-op visit in 6 weeks. So Dr. Chapman, he had mentioned, do you have like a checklist? This is a slide that I stole from Dr. Schroeder. So this is, I guess, like a mental checklist almost. So for a single level degenerative spinal patient, if there's no motion or flexion extension, if there's no severe foraminal stenosis, if they're older patients, lower demand, and obese patients, Dr. Schroeder is more inclined to try not to put hardware and then focus on just isolated decompressions. Thank you.
Thanks, Ash. Yeah, I mean, I think this is a great case, right? When I started, whatever it was 7 years ago, I would have told this lady 100% she needs a fusion. She's got a little bit of motion on her flexion and extension films. And just the number of patients that I have had that are, old Caucasian women with osteoporosis that I put in hardware and that have had complications just is sky high. Whether or not it's, at 5.1, a T-lift cage subsiding or screws pulling out. I just think the likelihood that you're going to have a complication from the hardware in this patient, to me, is so much higher than the likelihood that you're going to have some kind of long-term issue. Particularly if you're doing, in this case, we did a unilateral decompression. We left the midline structures. We didn't touch the other side. I think all of those things kind of say, hey, listen, I think I can probably decompress this without having, in my mind, what's pretty significant increased morbidity in an older patient, right? In a 50-year-old patient, I don't think there's that much more morbidity, but in this patient, I do. I don't know. What about you guys? Chris, what would you have done?
Yeah, I'm in the same spot. Like, I think that rate, I think that like this is the new disc herniation where, like, in the old days, you get a second disc herniation, you get a T-lift. Like, turns out that was probably wrong. If you have a stable spondylolisthesis and you do decompression, even with the midline laminectomy, the number of that, the numbers that go along with that patient progressing to like some significant spondylolisthesis where they have recurrent symptoms or, increased back pain is probably 10%. Probably doing the 90% too big of surgery fusion is the wrong answer. So I'm with you. If I think there's a stable, non-mobile spondylolisthesis, I think I wouldn't testify against you, but it's probably the wrong move to do a fusion in that case. Like, I think the Euros for once are right.
Yeah. So you'll even do a full midline Lammy, take it down and not worry about it.
100. I did it this week, 100%. If
Okay.
I think it's a collapsed disc, stable spondy, this is like Card's classification, total collapsed disc doesn't move. I just cannot imagine it ever moves. And I'm waiting to see, like a patient prove it to me otherwise. TBI?
What about some of our other panelists?
Just for the decompression, she's relatively stable, and for all the reasons Chris just said. It's funny how we've come full circle. Well, not full circle. We keep going in circles. We should do a decompression infusion,
That's true.
decompression, and we go back again.
If I can kick in, this is a great topic, and thank you very much for doing it, and all you guys gave great presentations. But here's one of the most common problems that every single spine surgeon sees. And you got to remember there's an art and science to medicine. So in this one, the science kind of lets us down. To use one of Alex's favorite words, there's equipoise. You can't prove that any one technique is better than the other. And there's a technique that we didn't mention tonight that's kind of the blue plate special at TBI for the last decade or so has been indirect decompression with an ALIF and then percutaneous screws. And we can routinely do that with 2.5 hours or less of anesthesia time. And just like an ACDF, it kind of fixes everything. It fixes the mechanical pain, fixes any pain from ligamentous instability, and it decompresses the foramen and the central canal. So in our hands, that's what works the best. And I think that's where the art comes in when there's not good science, is any of these techniques will work. You got to tell the patient you're recommending what works the best in your hands and in your experience. But you have to be reasonable. If you're using a technique because that's what you've been told you should use and it's not working well for your patients, then you got to go try something else. But
you said lateral. You said what was your indirect decompression technique? Sorry, my internet faded.
Yeah,
lateral, posterior. Or
no, an ALIF, and then followed by percutaneous pedicle screws. So that's, as I said, that's kind of been our procedure of choice for a long, long time at TBI for a grade 1 to 2 degen spondy with stenosis and claudication.
So will you do that even? So I would do that at L5 S1, but I wouldn't do a 1 level L4 L5
all day long, every
anterior.
day. Yeah, somebody's doing that every day. But
82 years old. Jack Ziegler's still doing AP. Yeah. Okay, fine. What's your
no. I'm
not saying don't be stupid.
Take into consideration the patient's age. So Jack is talking about that average patient from their
it's 45
to
55 or 60, right?
What's your limit? What's your limit for ALIF in your mind?
As far as what?
For
BMIs?
Age. No, BMI.
Age.
I think it's the access surgeon.
Yeah, it's more physiologic. If they've got circumferential vascular calcification at 40 years old, we're not doing them at 4 or 5.
Sure.
But if they have clean vessels and they're nice and healthy, they're physiologically in good shape, we've done them to mid-60s and occasionally 70-year-old who's physiologically clean.
Yeah, that seems reasonable. Yeah, my line in the sand is never above 75, but never with a quotation marks.
So if you had somebody who had, acceptable neuroanatomy at 4.5, and you could do a lateral versus an ALIF, would you still do an ALIF on that patient?
Most of us would. Yeah, although there are some guys at TBI who like laterals, and in the right patient, they would probably do that. But, we're blessed with these wonderful access surgeons who can reproducibly and safely get L4-5 exposed to us. So, we're spoiled. Everybody doesn't have that luxury.
And Greg, it also depends on the age of the docs. Jack and I, we trained before the XLIFs came out, and we've never really adopted it because our anterior access surgeon is so good. Now, Mike Heisey, who's on, Mike, started with XLIFs from the very beginning. He's very slick, and we have several partners that are really slick at doing XLIFs. So, it's a great minimally invasive technique, and I think with the newer implants that can restore the lordosis and really have a nice size footprint, really are just as good as doing an ALIF. But in our hands, at least with our access surgeons, we can do a really slick job as well.
Is it
we certainly?
Sorry,
we certainly can do a good job with a lateral or an ALIF. I prefer the lateral if I think there's any chance I might be coming back to do 5-1 later with an ALIF. So leave that. That's
an answer, actually. That's a good point.
Yeah, I mean, I think that one of the things that I think is different in my practice now than it was when I started was, I mean, I think the indirect decompression, whether it's an ALIF or a lateral, really works fantastic, which is kind of counter to what the, traditional Rothman approach has been, which has always been, direct decompression at every level. So, interesting, different ways to kind of handle it.
And Alex wanted me to call you and tell you that you're out.
Thanks. For sure.
Greg, it's funny that you say that, because in the beginning, we always used to do, even if we did a 360 before we depended on the indirect decompression, would do a direct decompression. Then Mike Heisey started doing it, and he was showing cases at conference, and we said, well, did you do a decompression? No. And so then we all started to look at it, and I would start to do decompressions after the 360s and find that there wasn't any more decompression or wasn't any more compression. So then we all sort of migrated to what Mike had talked about. And as he said earlier, the chance of us going back for re-decompression that was indirectly decompressed is very, very rare.
Yeah, I mean, that's definitely my experience too. So, well, listen, guys, I appreciate everybody's help on this. I think, realistically, this is probably one of the most common things that comes into our office. And my takeaway from this is that, the science can't really justify which one of these is better. And so you do have to, look at the patient, understand what's going on with the patient. And then you also have to be honest about your own surgical skill set, right? Is this something that, whether or not it's an MIST lift that is going to have a, your own learning curve and going to take time and you're going to have to do, or an ALIF with the access surgeon, or an open PLDF or an XLIF, right? I think these all work. And the important thing is that, what can kind of work in your hands with, the patient specific comorbidities.
Hey, Chris and Greg, I had one more question. So talking to my colleagues in the malpractice capital of the US in Philadelphia, we've not talked about interspinous process spaces. Is this something that doesn't exist in your city, or is this passe? I mean, I still am a fan of those, and I use this for those intermediate stability type patients. I found to be surprisingly good, but am I a loner there? Would I get sued out of my bejesus in Philadelphia?
I don't think you get sued, but you get laughed out of your bejesus in Philadelphia if I saw you put one in.
I don't know. I mean, let's talk to my Texas friends here. What do you guys think about those? Is that just not cool, or is it something for specific patients?
Well, it's like anything else, Jens, you got to be real specific. I mean, we used a lot of Coflex for a long time, and then we participated in the
Limiflex.
Limiflex.
Flex.
And I think the Limiflex makes more sense because the Coflex created so much dead space. I personally had so many post-op hematomas. I said, I'm not doing it anymore. No matter how long you let the drain in, they still had a large dead space because of the Coflex device. But I have to tell you that, we have a lot of them in, and those patients did very well. Now, again, it was patient selection. They weren't more than, a 20% slip, not more than a grade 1, that is. And, you had to do a good decompression. And but I stopped doing them for that reason about the hematomas. When the Limiflex comes out, I think that's a good alternative, because at least you're locking the facet and you're still doing a decompression. Well, so it is an alternative, just like a minimally, like you showed the one case, or one of your fellows showed, Greg, of just doing the decompression of the stable grade 1 spondy at L5S1. So we have lots of ways of treating these, and unfortunately, we're all biased by our own experience. And that's what makes it hard. That comes into the art of what Jack was talking about.
Right. I mean, but that would be my comment is, right, I just don't think that you need, like, if you can get away with any of these interspinous spacers, you can probably get away with an isolated decompression. To me, I think they either need a fusion or they don't. And if they don't, I'm just putting in an expensive isolated decompression. So that would be the way I would see it.
Now, I will make a comment about the very first, or one of the cases your fellow showed, where you just did a regular decompression posteriorly and put pedicle screws in. Before all this interbody stuff came about, all the different cages, I really think that those fusions were more forgiving than the, interbody 360s or T-lift or X-lifts, because now we have such rigid fixation. If the patient is predisposed to degenerating to level above or below, I really believe that we accelerate. I don't have any data, but it's just sort of a gut feel. Whereas with the posterior pedicle screws, you still get a little bit of spring in that disc space. So who knows? Maybe someday we'll have the data.
I mean,
There was a paper by the AO Spine Knowledge Forum Degenerative and Spine Journal in 22 that looked at demographic clinical operative risk factors for lumbar degenerative disc disease. You can probably look. I know that Jeff Wong was on it, and Hans-Jörg Weisel and Tim Yoon was on it. And they did find that laminectomies that go up to the upper level of the instrumentation were a clear risk factor on the forest plot diagram. I just forgot the first author name, but this in 22, I'm fairly certain this is one of the main risk factors that they had identified.
So you're saying by me doing a 3 to 5 decompression and a 4-5 fusion, I'm increasing the rate of them breaking down at 3-4.
The AO Spine, our friends at the AO Spine Knowledge Forum Degenerative said that in their article in TSJ. I was mad at them that they published it in a certain other journal, but they came up with that, and they did a fairly systematic review. So it was a large undertaking. I think they had several thousand patients that they pulled out. So,
and Jens, the type of fusion, interbody or not, didn't make any difference.
I think they looked at that, and I think the main problem patients that I remember were elevated BMI. And facet joint violations. I can try to find it quickly, but it was a systematic review, meta-analysis of TSJ by the AO Spine Degenerative Knowledge Forum with Jeff Wong as one of the senior authors and Tim Yoon. And
so again, so let me ask you, so if you had a 3 to 5 decompression or 3 to 5 severe stenosis and a spondy at 4-5, you're fusing 3 to 5?
No, I actually fuse 4 to 5 if I have to fuse. I've fused far less. I've used far more interspinous process spacers. And I will do a midline sparing decompression at 3-4. We actually published that in about 10 years ago. We did a 3-dimensional loading model. And by maintaining the posterior ligamentous complex, you actually preserve more than 10% that we're always taught of tension bands. So it actually reduces rotational forces also. So by preserving the midline and doing a careful midline sparing partial facetectomy, we do help the biomechanics of that area. So I will do a midline sparing L3-4 decompression in that case. And if I have to fuse, I will fuse 4 or 5.
What about TBI? What would you guys do?
Probably the same as what Jens said. Just do a tissue sparing or facet sparing decompression at the 3-4 and the 5-1, and then do your regular decompression of 4-5 with your pedicle screws if that's where the spondy was. I think that I became less. I used to do what you did, Greg, routinely in the before, and then I started to see some patients fall off above. And that's why I soured. Now, again, it's not based on scientific data. I don't have a large study to prove it, but that's why I went to then just decompressing each individual level. It takes longer. It's more of a pain in the butt for us to do, but I think it's better for the patient.
Interesting.
Actually, I'd love to see you guys publish that because, then all the time that I spent doing those limited decompressions at the other levels was a waste of time.
We just didn't publish it.
So we've looked at like whether or not you should include a fusion or not in it, and our answer was no. But it's hard for us to compare because all of us do it the same way, right? Everybody does it. So we'll have to do some kind of multi-center study. We'll work on it.
That'd be great. Actually, maybe ChatGPT will tell us the answer.
Oh my gosh, for sure. Well, thank you, everybody. I really appreciate it. I think this has been a great talk. I look forward to doing it again.
Thank you.
Well,
very
listen,
much.
thanks, Greg. As usual, it was a great